Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. The rise of biological therapeutics, including monoclonal antibodies, cell and gene therapies, CGT, and biosimilars, has transformed modern medicine. Unlike traditional small molecule drugs, these products come from living systems, giving them great therapeutic potential, but also inherent complexity and variability. This complexity requires a sophisticated, integrated control framework to ensure patient safety, product quality, and safety for workers and the environment. This report offers a detailed guide to the principles and practices for the safe handling, manufacturing, and disposal of these advanced therapies. It covers key concepts of risk assessment, the tiered system of biosafety containment from Biosafety Level 2, BSL 2, to BSL 3, and the development and validation of standard operating procedures, SOPs, under current good manufacturing practices, CGMP. The main idea is that for these products, personnel safety, environmental health, and product quality are not separate goals, but are closely linked outcomes of a single, tightly controlled system where the manufacturing process itself determines the final product. Here are 10 brief learning objectives that cover the key concepts of biosafety and the handling of advanced biological therapeutics. First, it is important to distinguish among biologics, biosimilars, and cell and gene therapies based on their molecular complexity, origin, and regulatory pathways. One should also understand why the principle that the process is the product is fundamental to the regulation of biologics, given their inherent variability. A foundational biological risk assessment involves identifying key hazards, such as pathogenicity and transmission routes of agents, as well as procedural hazards like activities that generate aerosols. It is crucial to recognize specific biosafety risks associated with cell and gene therapies, including the potential for replication-competent viruses, insertional mutagenesis, and viral shedding. Additional objectives include differentiating the necessary engineering controls, facility design features, and work practices required at various biosafety levels, ranging from Biosafety Level 2 to Biosafety Level 3. The Biosafety Cabinet plays a critical role as a primary engineering control, providing protection for workers and maintaining product sterility under good manufacturing practices. The life cycle of standard operating procedures involves creating, obtaining formal quality assurance approval, and regularly updating them to ensure compliance. The use of aseptic process simulation, such as media fills, is justified as the primary validation tool for aseptic processing in cell and gene therapy manufacturing, with specific acceptance criteria. Proper decontamination methods are also outlined. For example, a tenfold dilution of household bleach is necessary for inactivating non-enveloped viruses like adenovirus and adeno-associated virus, whereas 70% alcohol is ineffective against them. Finally, immediate first aid and reporting procedures are mandated for personnel exposure incidents, such as needle sticks or splashes within a containment facility. Understanding the unique characteristics of biological products, biosimilars, and therapies involving cells and genes is crucial for developing appropriate safety and handling protocols. These products differ fundamentally from traditional pharmaceuticals in their origins, structures, and manufacturing processes. As a result, They require a distinct and more stringent regulatory and operational framework. Biological products, or biologics, are therapeutic preparations derived from living organisms or their components. These sources can include humans, animals, or microorganisms such as bacteria and yeast. Biologics are composed of large, complex molecules like proteins, sugars, nucleic acids, or a combination of these. The category encompasses a broad range of products, including vaccines, blood products, monoclonal antibodies, cytokines, growth factors, and living cells or tissues used for transplantation. Cell and gene therapies represent a highly advanced and specialized subset of biologics. Cell therapy involves administering healthy cells into a patient's body to replace or support damaged or diseased cells. Gene therapy, on the other hand, aims to treat diseases by replacing faulty genes, inactivating malfunctioning genes, or introducing new genes into the body. These therapies are typically delivered as a single dose and have the potential to provide curative treatments for various cancers and genetic disorders. A biosimilar is a biological product that is highly similar to an already Food and Drug Administration approved biological product, known as the reference product. Unlike generic drugs, which are structurally identical to their small molecule counterparts, biosimilars are not exact replicas due to the inherent complexity and variability of their manufacturing processes. They are approved through an abbreviated pathway that requires extensive data to demonstrate that there are no clinically meaningful differences from the reference product in terms of safety, purity, and potency. The primary motivation for developing biosimilars is to increase market competition and provide more affordable treatment options. The difference in safety and handling requirements between biologics and conventional drugs arises from their significant structural and manufacturing differences. While a small molecule drug like aspirin may contain as few as 21 atoms, a biologic can consist of over 25,000 atoms, resulting in a large, complex three-dimensional structure. These products are usually produced in living systems, such as engineered cell cultures, through a complex and lengthy process that requires constant monitoring and control. In contrast, small molecule drugs are produced through highly controlled and reproducible chemical synthesis. This manufacturing difference leads to the most important concept in the field of biologics: inherent variability. Because they are produced in living organisms, biologics are subject to minor, natural variations from batch to batch, and even within a single batch. Post-translational modifications, like glycosylation, can vary slightly, subtly changing the final molecule. This variability means that it is impossible for another manufacturer to create an exact copy of a reference biologic without access to the original's proprietary master cell bank and specific manufacturing process. This reality underpins the regulatory principle for biologics. The process is the product. The final product is not defined only by its molecular formula, but by the entire, validated manufacturing process used to produce it. Any change in the process, from the cell line used to the purification methods, can significantly alter the final molecule, potentially affecting its safety and effectiveness. This is why the regulatory pathway for a generic biologic does not exist. Instead, the biosimilar pathway was established, which does not assume complete identity, but demands a thorough demonstration of high similarity through extensive analytical, non-clinical, and clinical data. Consequently, biosafety and strict process control are not just quality measures. They are the key factors determining the product's fundamental features. Cell and gene therapies exemplify the process is the product paradigm, adding more complexity and risk. Chimeric antigen receptor, CAR, T therapy is a notable example of ex vivo gene therapy. In this process, a patient's T cells are collected, a procedure called leukapheresis, genetically modified in a manufacturing facility with a viral vector to express a CAR targeting a specific cancer cell antigen, expanded to billions, and then rain-fused into the same patient. The autologous, patient-specific nature means each manufacturing process produces a unique batch. This scale-out approach, where many small, individual batches are made, contrasts sharply with the traditional scale-up method of producing a single large batch for multiple patients. This model places a significant burden on SOPs and CGMP controls, which must be robust enough to produce a safe and effective product despite the inherent biological variability of each patient's starting material. Viral vectors are key delivery tools used to introduce genetic material into cells for gene therapies. The most common types are derived from adeno-associated viruses, AAV, adenoviruses, and lentiviruses, a type of retrovirus. The biosafety risk profile of a viral vector depends on several factors, including the pathogenicity of the parent virus it originates from, its ability to replicate. Most are engineered to be replication deficient, and, importantly, the nature of the genetic payload, transgene, it carries. Small molecule drugs originate from chemical synthesis, are small, less than 900 Daltons, and simple in molecular size and complexity, and involve reproducible chemical reactions in their manufacturing. Their inherent variability is negligible, and the regulatory standard for a copy is bioequivalence, identical active ingredient. They are often administered orally, with chemical toxicity and reactivity being the key safety and handling concerns. Traditional biologics, such as monoclonal antibodies, mAbs, originate from living organisms, e.g., CHO cells. They are large, more than 25,000 atoms, with a complex 3D structure and are manufactured through complex bioprocesses in living cells. They exhibit low but inherent batch-to-batch variation, and the concept of a copy is not applicable in a regulatory sense. Administration is typically via injection or infusion, and key safety and handling concerns include product sterility and patient immunogenicity. Biosimilars also originate from living organisms, but from a different cell line than the reference product. They share a large, complex 3D molecular structure with traditional biologics and are manufactured via a reverse-engineered bioprocess. Their variability profile must match that of the reference product. For regulatory approval, they must be highly similar, with no clinically meaningful differences. Like traditional biologics, they are administered by injection or infusion, with patient immunogenicity and comparability being the main safety and handling concerns. Cell and gene therapies, such as CAR-T, originate from patient, autologous, or donor, allogeneic, cells. They involve living cells and viral vectors, and their manufacturing process is individualized per patient or dose. They exhibit high variability in their starting material, and the regulatory standard for a copy is not applicable. Administration is via infusion or direct injection. Key safety and handling concerns include worker and environmental exposure to viral vectors, as well as product sterility and viability. Before handling any biological material, a thorough and systematic risk assessment must be conducted. This process forms the foundation of a safe laboratory environment, guiding the choice of appropriate containment measures, work practices, and personal protective equipment. It is not a one-time task, but a continuous process that must evolve with changes in procedures, personnel, and scientific knowledge. A biological risk assessment is a structured approach used to identify the hazardous traits of an infectious agent, the activities that could lead to exposure, the likelihood of that exposure causing a laboratory-associated infection, LAI, and the potential consequences of such an infection. The core principle of the biosafety in microbiological and biomedical laboratories, BMBL, guide is that all safety protocols must be based on a specific risk assessment. The assessment must consider both hazards related to the agent and procedural hazards. When evaluating agent-related hazards, it is important to examine several key factors. These factors include the pathogenicity and virulence of the agent, which refer to its ability to cause disease and the severity of that disease. Additionally, the routes of transmission should be considered. These are the ways an agent can enter the body, such as through parenteral inoculation, for example, needle stick injuries, splashes onto mucous membranes, ingestion, and inhalation of aerosols. It is also essential to assess the infectious dose, or the amount of the agent required to cause infection. The environmental stability of the agent, or how long it can survive on surfaces or in the air, is another critical factor. Furthermore, understanding the host range, or the species that can be infected by the agent, helps in assessing risk. Lastly, the availability of prophylaxis or treatment, including whether effective vaccines or therapies exist, plays an important role. Procedural hazards are equally important in this assessment. Activities that generate aerosols, such as centrifuging, vortexing, pipetting, and sonicating, or procedures involving the use of sharp objects pose the highest risks of unintentional exposure. These hazards must be carefully controlled to ensure safety. The National Institutes of Health, NIH, guidelines classify infectious agents into 4 risk groups, RG, based on their inherent pathogenicity to healthy adult humans. This classification serves as the starting point for a risk assessment. Risk Group 1, RG1. Agents are not associated with disease in healthy adult humans, posing no or low individual and community risk. Examples include non-pathogenic strains of E. coli K12 and adeno-associated virus, AAV. Risk Group 2, RG2. Agents are associated with human diseases that are rarely serious, and preventive or therapeutic interventions are often available. They present a moderate individual risk and low community risk. Staphylococcus aureus, hepatitis B virus, and human adenovirus are examples of RG2 agents. Risk Group 3, RG3. Agents are associated with serious or lethal human diseases, though interventions may be available. These agents carry a high individual risk but a low community risk. Mycobacterium tuberculosis and human immunodeficiency virus, HIV, are classified as RG3 agents. Finally, Risk Group 4, RG4. Agents are likely to cause serious or lethal human diseases for which interventions are not usually available. They pose both high individual and high community risks. Examples of RG4 agents include Ebola virus and Marburg virus. It is essential to recognize that risk group is not the same as biosafety level, BSL. The risk group indicates the hazard posed by the wild-type agent itself. In contrast, the biosafety level describes the necessary containment conditions for the specific work as determined by a full risk assessment. For example, although the parent virus for lentiviral vectors is HIV, a RG3 agent, most research using replication-deficient lentiviral vectors can be safely performed at BSL-2 or BSL-2 with enhanced practices, BSL-2+, because the risk has been reduced through engineering. The risk assessment for CGT products is a complex matrix, where the final required containment level is a function of multiple independent variables: the vector system, its replication status, the nature of the genetic payload, and the procedures being performed. Viral vector-associated risks pose several safety concerns. One primary issue is the potential generation of a replication-competent virus during manufacturing, which could occur through recombination events. Modern vector systems, such as third-generation lentiviral vectors, are designed to reduce this risk by separating essential viral genes onto multiple plasmids. Rigorous testing for replication-competent viruses is a vital quality control step before releasing a batch of vectors. Another significant concern is insertional mutagenesis. Integrating vectors, like lentiviruses, have the potential to insert therapeutic genes into the host cell's genome at sites that might activate oncogenes or deactivate tumor suppressor genes. Such events could potentially lead to cancer, representing a serious health risk for the patient. For workers exposed occupationally, this also presents a theoretical long-term danger. The function of the gene delivered by the vector is equally important. Vectors carrying potent oncogenes, toxins, or immune-modulating genes require higher levels of containment compared to vectors that carry only simple reporter genes. Patients receiving gene therapy in vivo may shed the viral vector in their bodily waste for some time after treatment. This shedding creates a potential risk of exposure for healthcare workers and family members, necessitating specific handling precautions for patient waste and materials. Finally, there is the issue of immunogenicity and seroconversion. Healthcare workers who are accidentally exposed to a viral vector can develop an immune response to it. Such a response could make them ineligible for future gene therapy treatments using the same type of vector. While the most serious risks of CAR-T therapy, such as cytokine release syndrome, primarily affect the patient, managing these products involves specific biosafety considerations. Because these products consist of human cells, they must be handled at a minimum of BSL-2 to protect workers from potential bloodborne pathogens, following OSHA standards. Additionally, the manufacturing process uses viral vectors, and waste streams will contain both residual vectors and genetically modified human cells, all of which must be classified and managed as biohazardous waste. The concept of biosafety for biosimilars differs greatly from that for CGT. In CGT, the emphasis is on containing a biologically active agent to safeguard workers and the environment. For biosimilars, the main safety concern is protecting patients from an unintended immune response, immunogenicity, caused by small, process-induced differences between the biosimilar and its reference product. The purified monoclonal antibody product itself is not an infectious agent and usually only requires basic biosafety handling, BSL 1. The real risk is clinical and invisible during handling. Small variations in the manufacturing process can change the protein's three-dimensional structure or glycosylation patterns, causing the patient's immune system to see it as foreign and develop anti-drug antibodies, ADAs. These ADAs can neutralize the drug's therapeutic effect or, in rare cases, cause severe adverse events, as tragically shown in cases of pure red cell aplasia linked to changes in an erythropoietin formulation. Therefore, the risk mitigation strategy for biosimilars is not physical containment, BSL, but strict process control, CGMP, and thorough analytical and clinical testing to demonstrate no clinically meaningful differences from the reference product. A comprehensive risk assessment for a genetically modified virus product should follow a structured and well-documented process. The first step involves identifying hazards related to the genetic material of the parent virus. This includes classifying the risk group of the virus and fully characterizing the vector system used, such as its method of generation and replication status. It also involves analyzing the transgene inserted into the vector, considering whether it is an oncogene or a toxin. Next, procedural hazards must be identified. This involves creating a detailed process map of each experimental or manufacturing step and pinpointing potential hazards. Such hazards include procedures that generate aerosols, the use of sharp objects, or handling large volumes or high concentrations of materials. Following hazard identification, the appropriate biosafety level and mitigation strategies should be determined. The biosafety level is selected based on the hazards associated with the agent and the procedures involved. Once established, the hierarchy of controls should be applied to mitigate these risks. Engineering controls are essential and include the use of primary containment devices such as biological safety cabinets, sealed centrifuge rotors, and closed-system manufacturing equipment. Administrative controls are also critical. These involve developing and implementing detailed standard operating procedures, providing comprehensive and documented training to personnel, restricting laboratory access to authorized individuals only, and establishing a medical surveillance program. Personal protective equipment must be specified for each task. This includes items such as laboratory coats or gowns, gloves, eye and face protection, and, if needed, respiratory protection. The entire risk assessment, including the proposed mitigation strategies, should be formally reviewed and approved by the Institutional Biosafety Committee before any work begins. This approval is a regulatory requirement for institutions receiving funding from the National Institutes of Health for recombinant DNA research. Finally, the risk assessment should be treated as a living document. It must be maintained, regularly reviewed, and updated whenever there are changes in any part of the process. The output of the risk assessment is the determination of the appropriate biosafety level, BSL. Each level represents an escalating combination of laboratory practices, safety equipment, and facility design features engineered to contain biohazardous agents of increasing risk. Biosafety Level 2 is the foundational containment level used for a wide range of clinical, diagnostic, and research activities involving biological agents. This level of biosafety provides the necessary safety protocols and facilities to handle potentially hazardous biological materials securely. BSL 2 is appropriate for work involving agents that pose a moderate potential hazard to personnel and the environment, corresponding to RG2 agents. Critically, BSL 2 is the minimum containment level required for any work with human-derived blood, body fluids, tissues, or primary cell lines. due to the risk of exposure to bloodborne pathogens like hepatitis B virus and HIV. This makes BSL-2 the baseline for handling all cell therapy products. Standard microbiological practices form the bedrock of safe handling and include restricting access when work is in progress, posting biohazard warning signs, strictly prohibiting eating, drinking, and applying cosmetics, implementing procedures to minimize the creation of splashes or aerosols, and adhering to safe sharps practices, e.g., never recapping needles, using puncture-resistant disposal containers. The primary barriers, which serve as the first line of defense, include both personal protective equipment and specialized safety equipment. Personal protective equipment required in this context encompasses laboratory coats or gowns, gloves, and eye protection such as safety glasses or goggles. One of the most critical pieces of primary containment equipment at Biosafety Level 2 laboratories is the Class 2 Biosafety Cabinet. This cabinet must be employed for all procedures that have the potential to generate infectious aerosols or splashes. Additionally, other devices like sealed centrifuge rotors or safety cups are utilized to contain aerosols during high-speed centrifugation processes. The laboratory itself acts as a secondary barrier to ensure safety. Facilities operating at Biosafety Level 2 must have doors that can be self-closed and locked to separate the laboratory space from public access areas. A sink for hand washing and an emergency eye wash station should be easily accessible within the laboratory. Additionally, an autoclave or another validated method of decontamination must be available for treating laboratory waste to prevent contamination. The level known as Biosafety Level 2 Plus or Biosafety Level 2 Enhanced is not officially recognized in national or international guidelines. However, it is a widely adopted practice within institutions. This level serves as a practical solution for work where the risk assessment indicates that the standard precautions associated with Biosafety Level 2 are insufficient, but the full engineering controls and cost of establishing a Biosafety Level 3 facility are not justified. It is often used in research involving replication-incompetent lentiviral vectors or large-scale cultures of certain risk group 2 agents. Essentially, Biosafety Level 2 Plus acts as a bridge by incorporating select practices and enhancements from Biosafety Level 3 within a Biosafety Level 2 framework. In terms of work practices, all open manipulations of the infectious agents are strictly performed within a certified biological safety cabinet. Decontamination procedures for waste are often more rigorous than standard protocols, and a laboratory-specific biosafety manual that details all procedures is required. Personal protective equipment requirements are also elevated beyond those typical for Biosafety Level 2. This generally includes the use of disposable gowns with solid fronts and back closures instead of reusable laboratory coats. Additionally, double gloving is recommended, and respiratory protection such as a fit-tested N95 respirator may be required based on the risk assessment. Access to the laboratory is more tightly controlled to ensure safety and security. One of the most significant enhancements is the requirement for inward directional airflow, which means the laboratory is maintained at a negative air pressure relative to adjacent corridors or offices. This engineering control helps contain aerosols within the laboratory in case of an accidental release outside of a biosafety cabinet. Additionally, a hands-free sink and an eye wash station are typically required within the designated Biosafety Level 2 or higher laboratory space. The transition from BSL-2 to BSL-3 marks a fundamental shift in containment philosophy. While BSL-2 focuses on practices and primary barriers to protect the worker, BSL-3 utilizes sophisticated engineering controls to protect the worker, the community, and the environment. The facility itself becomes an active containment system. The Biosafety Level 3 is required for work involving indigenous or exotic agents that could cause serious or potentially lethal diseases when inhaled, known as Risk Group 3 agents. The facility must incorporate specific design features and engineering controls to ensure safety. Access to the laboratory must be controlled, with the laboratory being physically separated from unrestricted traffic flow. Entry is regulated through an anteroom or a two-door airlock system, where one door must be closed before the other can be opened to prevent contamination. The laboratory environment must be sealed. All penetrations in the walls, floors, and ceilings, such as those for pipes and conduits, must be airtight and sealed. Surfaces should be smooth, non-porous, and resistant to chemicals to facilitate easy cleaning and decontamination. The specialized heating, ventilation, and air conditioning system is the most critical engineering control in this context. Facilities classified as Biosafety Level 3 must have a dedicated, single-pass ventilation system. This means that air should never be recirculated back into the laboratory or other parts of the building. The system must be designed to maintain a continuous inward directional airflow, creating a negative pressure environment. This configuration ensures that air always flows from the cleaner areas, such as corridors, into the contaminated laboratory spaces. Additionally, the exhaust air is filtered through high-efficiency particulate air filters before being safely discharged outside the building, away from any air intakes. Operational protocols and strict work practices require that all procedures involving infectious agents be conducted within a primary containment device, such as a Class 2 or Class 3 biological safety cabinet. Access to these areas is strictly limited to personnel who have completed a comprehensive, documented training program and have demonstrated proficiency in all Biosafety Level 3 standard operating procedures. An occupational health program must be in place, including medical surveillance and the availability of immunizations. Personal protective equipment is more extensive and includes solid front protective clothing, such as wraparound gowns or coveralls, which must be decontaminated within the facility before being laundered. Respiratory protection is often necessary to ensure safety. All waste generated within the Biosafety Level 3 laboratory must be decontaminated before removal, typically using a pass-through autoclave with one door opening into the laboratory and the other opening outside the containment barrier. Facility verification and certification are essential steps before a Biosafety Level 3 laboratory can be used. The process ensures that the engineering controls are functioning as designed. It involves testing the heating, ventilation, and air conditioning system under simulated failure conditions, such as power loss or fan failure, to verify that containment is maintained and airflow does not reverse. This certification must be carried out at least once a year and whenever significant modifications are made to the facility or its systems. The process includes annual certification of all biosafety cabinets, integrity testing of high-efficiency particulate air filters, and calibration of monitoring devices such as pressure gauges. In the field of therapeutic products, ensuring biosafety is fundamentally connected to the quality of manufacturing processes. Standard operating procedures are essential documents that translate safety and quality principles into actions that can be consistently reproduced and thoroughly audited. In the highly regulated environment of cell and gene therapy, these procedures must meet both biosafety standards and the strict requirements of current good manufacturing practices. Such measures are crucial to maintain high standards of safety and quality throughout the manufacturing process. The standard operating procedure lifecycle in a current good manufacturing practice environment. A standard operating procedure is a detailed, step-by-step written instruction that outlines how to perform a specific task. In a regulated manufacturing environment that complies with current good manufacturing practices, adherence to standard operating procedures is mandatory. The fundamental principle is that if an action was not documented, it is considered not to have occurred. The management of these critical documents follows a defined life cycle to ensure consistency, compliance, and traceability throughout their use. The creation and drafting of standard operating procedures are based on validated process parameters and risk assessments. These procedures must be written with sufficient clarity and detail to ensure that any trained operator can perform the task consistently. Draft versions of standard operating procedures undergo a formal review process involving subject matter experts from relevant departments such as manufacturing and quality control. They must be formally approved by the Quality Assurance Unit before being implemented. Personnel are required to be formally trained on the current, effective version of a standard operating procedure before they are authorized to carry out the associated task. This training must be documented for record-keeping purposes. During execution, all activities must be performed exactly as described in the standard operating procedure. Each step is documented in real time on the corresponding batch record, creating a complete and traceable history of the manufacturing process. Standard operating procedures are not static documents. They require regular review and revision. Typically, this review occurs annually to ensure they remain current with best practices and regulatory requirements. Any modifications to the procedures must go through a formal change control process, which includes an assessment of the impact on product quality and safety. When a standard operating procedure is superseded by a new version, the older version is formally retired. Obsolete procedures are removed from active use, but are archived for a designated period to maintain a complete historical record of manufacturing processes. The complexity of CAR-T manufacturing demands a comprehensive suite of SOPs covering every aspect of the process, from patient material receipt to final product release. The key standard operating procedure categories encompass several critical areas. Material and personnel flow procedures define the movement of materials, waste, and personnel into and out of the cleanroom environment to prevent cross-contamination. Environmental control procedures cover gowning protocols, cleaning and disinfection of the facility and equipment, as well as the environmental monitoring program, which includes air and surface sampling. Aseptic processing involves detailed, step-by-step instructions for every unit operation, such as thawing starting materials, cell isolation and enrichment, cell activation, gene transfer through transduction, cell expansion within bioreactors, cell harvesting and washing, formulation, and cryopreservation. Equipment operation, calibration, and maintenance procedures apply to all equipment, including biosafety cabinets, incubators, centrifuges, and automated cell processing systems. Quality control testing procedures address all in-process and final release tests to ensure product identity, purity, safety, such as sterility, mycoplasma, endotoxin levels, and residual host cell material, and potency. Waste management procedures specify the segregation, decontamination, and disposal of all biohazardous waste, including residual patient cells, viral vectors, and contaminated consumables. Because cell and gene therapies are administered through methods other than the digestive tract and cannot be sterilized through a final sterilization process, they must be produced using aseptic processing techniques. Validating this process is a critical requirement under current good manufacturing practices. The primary method used for validation is known as the aseptic process simulation, commonly called a media fill. In a media fill, the entire manufacturing process is carried out using a sterile microbiological growth medium, such as tryptic soy broth, instead of the actual cells and reagents. The purpose of this procedure is to challenge the process's ability to maintain sterility under the most challenging conditions. A successful media fill provides objective evidence that the design of the facility, equipment, standard operating procedures, and the practices of personnel work together effectively to produce a sterile product. A media fill protocol for a chimeric antigen receptor T-cell manufacturing process must simulate every aseptic manipulation involved. The setup involves preparing the cleanroom and all equipment, such as biosafety cabinets, incubators, and automated processors, as one would for a routine production run. During the simulation of unit operations, operators use a growth medium to replicate each step of the process. These steps include thawing the starting material, connecting and transferring liquids through tubing sets, taking in-process samples, performing cell washing and concentration procedures, and filling the final product bags. The simulation must incorporate worst-case conditions to ensure robustness. This includes the maximum number of personnel present in the cleanroom, the longest conceivable process duration, and all planned or foreseeable unplanned interventions. Such interventions may involve making aseptic connections or adjusting equipment during the process. Following the completion of these manipulations, the filled units are incubated for a period of 14 days. During incubation, they are typically cycled between two different temperature ranges. For example, 7 days at 20 to 25 degrees Celsius to monitor fungal growth, and 7 days at 30 to 35 degrees Celsius to detect bacterial growth. After incubation, each unit undergoes careful inspection for signs of turbidity, which indicates microbial contamination and potential process failure. This thorough evaluation ensures the integrity and safety of the process. The acceptance criterion for a media fill is 0 contaminated units. For initial validation of a process or facility, regulatory agencies typically require 3 consecutive successful runs. A single contaminated unit results in a failed run and necessitates a full investigation to determine the root cause, implementation of corrective and preventive actions, CAPA, and a repeat of the validation runs. In the manufacturing of cell and gene therapies, biosafety and current good manufacturing practices are 2 closely interconnected aspects. Many controls in this field serve dual purposes. For example, a Class II biological safety cabinet functions as a primary engineering control, ensuring biosafety by protecting operators from the product. At the same time, it creates a highly clean environment that meets ISO 5 or Grade A standards. This environment is a requirement of current good manufacturing practices designed to protect both the product from contamination by the operator and the surrounding environment. This convergence indicates that a breach in a septic technique can simultaneously be considered a biosafety incident and a deviation from current good manufacturing practice requirements. For example, a failed aseptic connection might allow environmental microbes to enter the product, jeopardizing patient safety. At the same time, it could enable genetically modified cells or viral vectors to escape the system, thereby exposing the operator to potential hazards. The media fill process is essential because it serves as a validation of both sterility assurance, which is a requirement under current good manufacturing practices, and the integrity of process containment, which is crucial for biosafety. Furthermore, the unique nature of therapies using the patient's own cells presents challenges to traditional validation methods. Since each batch begins with individual patient material, it is impossible to produce 3 identical validation batches. Instead, the validation efforts are focused on the manufacturing platform, including the closed system, the automated equipment, and the standard operating procedures. The primary goal is to demonstrate that the platform process is robust and capable of consistently transforming variable input, such as patient cells, into a final product that meets all pre-established critical quality attributes related to safety, purity, and potency. This shift emphasizes the importance of rigorously validated standard operating procedures and highly skilled operators, as they serve as the consistent elements within a process characterized by high variability. The most sophisticated facility designs and meticulously written SOPs are rendered ineffective without a highly trained, proficient, and disciplined workforce. Operational excellence in a CGT facility is built upon a foundation of continuous training, rigorous adherence to procedures, and a deeply ingrained culture of safety and quality. All personnel entering a current good manufacturing practice and Biosafety Level 2 or Biosafety Level 3 environment must undergo comprehensive initial training. This training covers aseptic techniques, cleanroom behavior, basic microbiology, site-specific standard operating procedures, and emergency procedures. Such training is not a one-time event. An annual refresher course is mandatory to reinforce best practices and to communicate any updates to procedures or regulations. The Biological Safety Level 3 training program involves a multi-phase, qualification-based process to gain unescorted access to a Level 3 laboratory. The process usually begins with theoretical training, which may include online modules covering risk assessment and containment principles. Following this, trainees participate in extensive, hands-on training specific to the facility, conducted under the direct supervision of an experienced mentor. Trainees are required to demonstrate proficiency in all critical procedures, such as the proper donning and doffing of personal protective equipment, use of biological safety cabinets, waste management, and emergency response protocols. Only after successfully meeting these requirements and demonstrating competency through both written examinations and practical assessments are individuals granted independent access to the laboratory. Aseptic processing proficiency is essential for ensuring the safety and effectiveness of controlled environments. The success of multi-million-dollar engineering controls relies heavily on the discipline demonstrated by operators on a moment-to-moment basis. Their proficiency functions as the most critical active safety system within the process. To qualify as proficient, operators must demonstrate flawless aseptic techniques and proper gowning procedures. This proficiency is continuously verified through successful participation in routine media fill tests, which are conducted at least once a year. Proper management of biohazardous waste is critical for protecting both personnel and the environment. All waste generated from CGT processes must be considered biohazardous and handled accordingly. Decontamination methods include several essential procedures. Autoclaving involves steam sterilization, which is the preferred method for decontaminating solid waste such as used personal protective equipment, plasticware, and animal bedding. It is important to regularly verify the effectiveness of each autoclave cycle using biological indicators, such as spores from the bacterium Bacillus styrothermophilus. Chemical disinfection is used primarily for decontaminating liquid waste and work surfaces. Selecting the appropriate disinfectant is critical, and it must be validated specifically for the agents in use. A freshly prepared dilution of household bleach at a ratio of 1 part bleach to 10 parts water, which provides a final sodium hypochlorite concentration of over 0.5%, is an effective broad-spectrum disinfectant for many agents, including enveloped viruses such as lentivirus. It is essential to allow sufficient contact time, typically between 15 and 30 minutes, for complete inactivation. It is also important to note that some common disinfectants, like 70% alcohol, are not effective against non-enveloped viruses such as adenovirus and adeno-associated virus. Clear procedures must be in place for the segregation of waste at the point of generation. Sharps must be placed directly into puncture-resistant containers. Solid waste goes into labeled, red biohazard bags, which are then placed in rigid, leak-proof secondary containers. Liquid waste is typically collected in a vacuum flask containing a chemical disinfectant before being disposed of down a sanitary sewer, in accordance with local regulations. All waste containers must be decontaminated on the outside before being removed from the BSC or laboratory. Despite the best controls, accidents can happen. Having robust, well-rehearsed emergency SOPs is essential to mitigate the consequences of a spill or exposure. The effectiveness of these plans in a real event is directly proportional to the realism and frequency of training and drills. When a spill occurs inside a biological safety cabinet, this is considered the most contained scenario. The operator should keep the biological safety cabinet running, cover the spill with absorbent material, and apply an appropriate disinfectant. The disinfection should start from the outside of the spill and work inward. After allowing the disinfectant to remain in contact with the surface for the required amount of time, the materials used for cleanup should be disposed of as biohazardous waste. Following this, the interior of the biological safety cabinet should be thoroughly decontaminated. In the event of a spill outside a biological safety cabinet, the situation is more serious. The immediate response should be to alert others and evacuate the area. It is important to close the door to contain any potential aerosols. The area should remain unoccupied for at least 30 minutes to allow aerosols to settle. Trained personnel, equipped with appropriate personal protective equipment, including respiratory protection, can re-enter the area to decontaminate the spill using a spill kit. It is also essential to report the incident immediately to the biosafety officer. Personnel exposure response procedures should be clearly posted and understood by all staff. In the event of a needle stick or cut, the wound must be washed with soap and water for at least 15 minutes. If there is a splash to the eyes, nose, or mouth, the affected area should be flushed continuously for at least 15 minutes at an emergency eye wash station. All exposures, regardless of how minor they may seem, must be reported immediately to the laboratory supervisor and the occupational health and safety departments of the institution. The individual who has been exposed should receive an immediate medical evaluation. For certain exposures, especially those involving replication-competent or high-risk lentiviral vectors, post-exposure prophylaxis with antiretroviral medications may be recommended. Such treatment should be initiated as soon as possible, ideally within 2 hours of the incident. The history of biologics shows that small changes in manufacturing can lead to increased immunogenicity and serious adverse events. Examples like Eprex-associated pure red cell aplasia, where a change in formulation stabilizer triggered an autoimmune response against erythropoietin, highlight the importance of the process is the product principle. They emphasize why regulatory agencies require extensive analytical and clinical data to demonstrate biosimilarity and why any manufacturing change after approval is carefully scrutinized. Early CAR-T manufacturing processes were often open and manual, posing significant risks of product contamination and operator exposure. Case studies from companies using closed, automated manufacturing platforms like the CliniMax Prodigy show a major improvement in both cGMP compliance and biosafety. These systems decrease manual handling within a BSC, thereby reducing the likelihood of human error, lowering contamination risk, and increasing process consistency. A clear example of how engineering controls can boost both product quality and worker safety. The history of microbiology is marked by incidents involving laboratory-acquired infections, which have significantly influenced the development of biosafety practices and containment equipment, such as biological safety cabinets. Recent high-profile safety lapses at major research institutions demonstrate that even the most advanced safety systems can be vulnerable to human error, procedural deviations, and a declining safety culture. These events underscore the critical importance of ongoing training, strict oversight, and the creation of a work environment where staff members feel comfortable reporting concerns without fear of retaliation. The safe and effective development of biological products, cellular and gene therapies, and biosimilar medicines requires a comprehensive and deeply integrated approach to quality and safety. The inherent complexity and variability of these products, which originate from living systems, necessitate a departure from the traditional paradigms used for conventional pharmaceuticals. The guiding principle that the manufacturing process defines the final product is more than just a regulatory slogan. It is the central concept that connects all aspects of facility design, process development, and daily operations. A robust biosafety program starts with a thorough, multifaceted risk assessment. This assessment considers the biological agent involved, the procedures used, and the personnel working with such products. Based on this evaluation, appropriate containment measures are implemented, ranging from basic practices akin to Biosafety Level 2 to advanced engineering controls similar to Biosafety Level 3. For the next generation of cellular and gene therapies, which often carry complex risk profiles, enhanced biosafety practices between Biosafety Level 2 and Biosafety Level 3 provide an important, risk-based intermediate level of control. Within this containment framework, standard operating procedures that comply with current good manufacturing practices form the backbone of reproducible and safe manufacturing processes. Validating these procedures through aseptic process simulations is crucial, as it verifies that the controls are effective while simultaneously protecting the product from contamination and ensuring the safety of personnel from exposure. Ultimately, the success of this entire framework depends heavily on the human element. A well-trained, competent, and vigilant workforce, supported by a strong organizational culture focused on safety and continuous improvement, constitutes the most critical control measure. As these transformative therapies continue to develop and advance, unwavering adherence to these integrated principles of biosafety and quality will be essential. This commitment is vital for realizing their full therapeutic potential while safeguarding patients, workers, and the public. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.